Cervical cancer, it's now preventable disease. Well, I'm just going to have this orange, and this orange, I'm hopefully going to prevent cancer, but this doesn't prevent cancer as much as we're going to learn about just vaccinating against the virus that basically can eliminate a disease. It's a game changer. So let's take a look at what normally kills us. So this is actually data from 2023, and you can see the number one killer at this point in time are cancers. My disease, heart disease, used to be the number one. And right now we're saying in Canada, over 86,000 people died in 2023 from cancer. Heart disease killed about just 58,000 people. Stroke, another 13,000. You can see COVID, diabetes, other diseases as well. So we have to think about how do we prevent cancer? I don't have a vaccination for heart disease, but we have vaccinations that can do things really well. And the story of cervical cancer, wow, what a game changer. Tell us more. What's happened? Next slide, please.
No, of course, I think when you mention cancer, I think most people who are not familiar with cancer don't realize much of it can come from infections. Now, not necessarily from COVID, although there's a little bit of evidence that maybe things like COVID can also accelerate some other types of cancers, some other conditions. But now we're in flu season, so we just want to quickly remind everyone if you're at risk, and if you're at risk, you would know the main risk factor is age. If you're above 65 and newborns as well, if you have a newborn, vaccines are even more crucial because they don't have great immune systems. Initially, in the first few months of life, you have your protection from your mom, but then you're on your own essentially until you get a vaccine. So, quick reminder: get the COVID one, flu, RSV, shingles, very very important one, especially for dementia. Data coming out recently that people who've been vaccinated against shingles they have less dementia. I don't know how strong that evidence is, but that's an excuse for us to talk about it a little bit more, and pneumococcal pneumonia. And the other point that I always mention to people is things like flu, RSV, COVID, they increase your risk of a heart attack or an event, a coronary event, in a few months afterwards. There was that nice trial, Dr. Curnew, I don't know what the trial name was in 2021, that decreased heart attacks in people who went to emergency department. They got their flu vaccines and they saw heart attack reduction just from the flu vaccine. So that was pretty impressive. I always remember that.
Yeah,
Uh,
it's called IME,
IME, yes.
and it took in 3 years, three flu season years during the winter time, people came to the hospital. They were admitted for their heart attack. And what happened was that they got the flu shot or no flu shot, and it decreased total cardiovascular events by 28%. So that was very powerful. And you mentioned this is that a lot of things damage vessels. We know that banging your head causes concussions, and we know that influenza, RSV, pneumonia, any major infection, shingles as well, that if you have any of these infections for the next few months afterwards, your risk of a heart attack varies between 2 and 5 times that amount. Um, Usually at least doubles or 3 times the amount. And damaging vessels is not a good idea. And right now in Canada, we have really good vaccinations. I know in the States, there's a whole political scandal and other places as well. So um, I'm going to get every vaccine I can think about. So we're going to learn a little more about that. Next slide, please.
Yeah, so what I say to myself and some other family members and friends is that one of the best inventions in the world in health, in public health, antibiotics, vaccines, statins. These three are the ones that I always mention. Statins
Mm.
underutilized for the reasons we all know, Dr. Curnew, but two of them is about viruses. We're going to talk about viruses tonight.
So one of the things I'll do mention, this is actually COVID. COVID is actually last year peaked in as a two peak season in the States. This is actually wastewater data from the States. I'm not sure we're collecting it well in Canada, but August of last year was the number one peak. This year, there was a peak in the wintertime, and there's a second peak that started in late summer as well. And so it's important. So
And we are here
I
right now. If you look at my cursor, so going up here. That's in the
think,
U.S. still, but
yeah,
I would
and
presume
we're
it's not too different here.
yeah. You can see the first peak in January there. You can see that was this was 2025, but in 2024, there was a higher peak in August than there was in the wintertime. And you can see
Hmm.
that this peak is is going up. So we're now entering flu season, influenza, and RSV as well right now. And what we haven't put in here is preventing our pneumococcal pneumonia that also too can also damage the heart. Any major infection can damage your blood vessels, and some in particular. So the recommendation for COVID, anybody over the age of 6 months or greater is eligible for a COVID vaccine. And I would consider, if I'm a healthy person, getting a COVID shot once a year, over the age of 65, twice a year. And I'll remind you, in the States, influenza killed just under 300 young kids last year, mean age of around 7 years of age. I'll repeat that. Influenza last year in the United States killed close to 300 young children. And basically, these are potentially preventable illnesses by vaccine. And half the kids that actually died from influenza had no medical problems whatsoever. So it's playing Russian roulette. These are seat belts to your insides, and think about how you want to protect yourself. Next slide, please. Anything else you want to say about that?
No,
Oh,
I think that was
hepatitis
well said. Yeah.
hepatitis B is interesting. Is that when I started medical internship, we saw a lot of chronic hepatitis B. I got vaccinated for hepatitis B, and there's a chronic form that can lead to cirrhosis of the liver and to cancers called hepatomas. We now have a strategy in place that when you leave hospital, or when you're born, excuse me, within 24 hours of a baby being born, they all get vaccinated against hepatitis B. And because chronic hepatitis B is a preventable illness by the vaccine. And if mother has hepatitis B, she can transmit hepatitis B to her baby. And if baby get hepatitis B, it can go into a chronic form 85% of the time. And chronic hepatitis B is a bad disease. So here's another disease that's preventable. And just another examples of the power of vaccines. Next slide, please. Next slide, please. And now we're going to talk about today's discussion right now. This is actually really remarkable in my practice of medicine, is that so many things have changed, diseases have changed, and I'm a cardiologist, and I've been treating people with all sorts of heart disease. When people have to go to hospital to treat their cervical cancer and have heart disease, it adds risk. But we can prevent this. So the team's going to really tell us how we prevent all this from happening. Fire away. Excited to hear more.
Thank you, Dr. Curnew, for your information and insight. So we'll switch gears a little bit here, and we're going to talk about cervical cancer and the new screening guidelines that have been enacted recently. So to start off with, cervical cancer at a glance, as you can see, it is cancer of the cervix. It usually happens around 40 to 49 years old. Some of the risk factors, and we'll go in more detail about risk factors, but just in general, the main one is human papillomavirus, or HPV. STIs, in particular, getting repetitive STIs puts you more at risk for cervical cancers, and having multiple.
What's an STI?
An STI is a sexually transmitted infection. So these include things like gonorrhea as well as chlamydia. And then, of course, having multiple partners, mainly because that makes you more predisposed to the sexually transmitted infections, as we mentioned, and even to HPV. When it comes to at-risk populations, and again, we'll talk more about this in detail in a minute, these include individuals who are newly immigrated to Canada, First Nations communities, individuals who are geographically isolated, as well as sex trade workers and individuals in low socioeconomic status, so individuals who might have some financial difficulty. And all of this is kind of based in and around the lack of access to care, and often the lack of preventative care. And so what we'll highlight in this talk in particular is how important prevention is to cervical cancer. And sadly, a lot of these communities don't have the access oftentimes to the prevention. So we can go to the next slide. Perfect. So as mentioned, we're going to go more in detail to the risk factors. So one of the strongest factors in cervical cancer risk is the infection of high-risk HPV, which includes includes these particular strains, so 16, 18, 31, 33, and 42, and sexual behavior such as participating in sexual activities at a young age or having multiple partners can again increase this opportunity for an HPV infection. But HPV alone often isn't sufficient to develop cervical cancers. There are several cofactors which can contribute to disease development. So, for example, being a smoker significantly increases the risk of both precancerous lesions as well as invasive cervical cancer. We know that for immunocompromised people, they don't have the ability to defend against HPV infections all too well. So usually in Ontario, they are recommended to get that preventative testing, which we'll talk about in a minute, every 3 years, versus individuals who might be HPV negative and immunocompromised are recommended to get it every 5 years. And some examples for individuals who might be immunocompromised, if they have like an autoimmune disease like Lyme disease, for example, that's sort of the population that we're looking at. Individuals with long-term inflammation from other sexually transmitted infections such as chlamydia, herpes, that also might impact their immune system's ability to fight off pathogens. And so it makes them more vulnerable to HPV infections and then ultimately to cervical cancer. So to summarize, some of the major risk factors is smoking, being immunocompromised, so having those autoimmune diseases, and having repeated history of those sexually transmitted infections, which increase your exposure to HPV, which again can lead to cervical cancer. We can go to the next slide.
Cervical cancer is one of the most preventable cancers, and prevention can start with protection against HPV, the main cause. So the HPV vaccine is highly effective and is recommended for young adults, ideally before they become sexually active. But these are still effective later periods in our lives as well. There is routine screening with pap smears and HPV testing, which can help detect changes early before they turn to cancer. Practicing safe sex, like using condoms, and reducing the number of partners lowers the risk of HPV transmissions and exposure. Quitting or avoiding smoking is also important, since smoking makes it harder for the body to clear HPV infections as well. Next slide, please.
All right, so now to kind of delve a little bit deeper into the signs and symptoms of cervical cancer. So usually in the early stages, people can be asymptomatic or they might not have a lot of symptoms. So they might not know if they have cervical cancer yet. Some people may see some watery brown or red discharge, as well as postcoital bleeding, which means bleeding after intercourse. So that's kind of mainly the early stages. In the later stages, you'll definitely see some more bleeding. So this is again like postcoital bleeding, postmenopausal bleeding, or irregular bleeding. You might also experience some pelvic pain, vaginal discharge, some back pain, as well as sciatica, having difficulties with like your bowels or other bladder symptoms, having flank pain, as well as lower limb edema. As you can imagine, these symptoms are not necessarily unique to cervical cancer, so you can have various differential diagnoses based on these symptoms, but it's usually in combination with other signs and symptoms, such as things that are more particular, like a cauliflower lesion that you might find on the cervix, as well as friable raised like red areas on the cervix. So it's kind of in tangent with coming with these signs and symptoms, but also doing the necessary investigations as well. We can go on to the next slide. So while cervical cancer affects people across Canada, there are certain groups, which I mentioned previously, that are disproportionately impacted. So first, geography and income does matter. So rates are higher in rural and remote areas compared to urban ones, and in lower income neighborhoods compared to higher ones. So these disparities are often reflected because of the reduced access to health services. So there's fewer screening opportunities as well as structural barriers. But access isn't the only challenge. As figure 15 shows, many people avoid pap smears because they feel that the test isn't necessary. Their doctor hasn't brought it up to them yet, or there's like a lack of time and discomfort. So this is where the new HPV self-sampling kits can make a big difference. They tend to be quite accurate, they're private, they're convenient, and they usually help for many to overcome these barriers and reach people who may not otherwise have access to that sort of screening. So we can go on to the next slide.
I can talk about this a little bit. The other question is, how about men? So one thing that we want to clarify is HPV infection doesn't only lead to things like cervical cancer. Even people without a cervix, it can cause other types of cancer. You can see here that nearly 2/3 of HPV-associated cancers are non-cervical. And you can see some of the types here. We have anal cancers, we have penile cancers, and we have it can spread to your neck and head and other areas. So the idea is that cancer prevention from HPV is not just for women or people with a cervix. It's also for men because of this, and that's why we have vaccinations in schools. And we'll talk more about what age people have to get it and who has to get it. But we just want to put a quick note that it is not just for one sex; it's for both.
All right, so when it comes to the conversation around genetic components and cervical cancer, at this point, there's no genetic link that we found. So there's no particular gene that causes cervical cancer or puts you more at risk. That's different than, for example, breast cancer, where people who might have the BRCA1 gene are more at risk of developing breast cancer. It's not necessarily the same with cervical cancer. There is research being done in the field, and some researchers have noted that the particular region on the DNA called the HLA region, if there is damage in that area, they might have some susceptibility to cervical cancer. But once again, this is very preliminary, and more research needs to be done. So at this point, there's not a whole lot of like genetics when it comes to your susceptibility or how likely it is for you to get cervical cancer. So we can go on to the next slide. So now we're going to talk about the prevention of cervical cancer. So we're going to talk a little bit about the old pap test and now the new HPV testing that has occurred. So when it comes to the old pap test, this was one of the most earliest screening tools in medicine to help detect abnormal changes in cervical cells before they become cancerous. So the pap test looked for precancerous changes in the cells of the cervix. These are abnormal cell changes that, if left untreated, could develop into cervical cancer over time. When cervical cancer appears abnormal but are not yet cancerous, this is called cervical precancer. These early changes often don't cause any pain or symptoms, which is why regular screening is really important. The pap test allows healthcare providers to detect these cell changes years before cancer develops, giving patients the opportunity to receive treatment, as well as have early prevention for cervical cancer. So some of the treatments that might be done on precancerous lesions or areas are laser therapy, cryotherapy, and sometimes even excision of those precancerous cells as well. It is now well established that nearly all cervical cancers, so 99.7% is a percentage, is caused by the human papillomavirus or HPV. So this discovery has now led to a more effective screening tool named, the HPV test or cervical screening test. And again, unlike the pap test, which looked for abnormal cell changes, the cervical screening test or HPV test is there to identify HPV, which is again one of the most common underlying cause of cervical cancers. And we can go to the next slide to talk a little bit more about that. So in terms of the new HPV, in starting with how it's taken. So it's taken very similar to the pap test. So you would make an appointment with your family doctor. You would come into clinic and they would do a speculum exam, and they would have a brush to insert and to kind of go in and around the area of the cervix. They would place it in a solution and then throw away the brush and send it off to the lab. So in that way, they're quite similar in the way that they are done. The old pap, very similarly, you would go in, go for a speculum exam, have a brushed brush, take the sample, and then send it off to the lab. What is different now is the age in which you would start screening. So it now starts at 25 and only if you're sexually active. And instead of happening every 3 to 4 years, it's now every 5 years. And usually the new screening guidelines recommend stopping at around 65 to 69, unless you are a high-risk individual. So for example, if a first-degree relative of yours, like a mom, has had previous cervical cancer, you would be expected to kind of continue the screening until 74. In terms of what happens after you get a positive result, you may be asked, depending on your risk factor, to repeat the exam, or you might be sent for colposcopy, which is another exam that's going to look a little bit more in detail to the cells of the cervix and once again, identify if you do or do not have cervical cancer. For this new test, what's great is that because 99.7% of cervical cancers are caused by HPV, it tends to be better at detecting cervical cancers, and it's also better at ruling out people who are negative. So in the previous PAP, there might have been a handful of false positives, and so this PAP is a little bit better equipped at not having as many people come up with those false positive results. So that's definitely an added benefit. We can go on to the next slide. So I mentioned briefly before a little bit about self-swabbing. At this point, when it comes to the HPV testing, self-swabs have been started to be rolled out in Ontario in a phase approach. So maybe not every area in Ontario has it, but it is eventually going to get there. However, in BC, in British Columbia, it has a wider rollout and they've seen a lot of good success when it comes to that. To note, they are not covered by OHIP. However, they do have similar accuracy. So if there is an individual who may be uncomfortable with getting an HPV test done because of previous traumas or sexual assaults, or they live in a really remote area that it's difficult for them to make the journey, and they want to keep up to date with their preventative health through swabbing, this is an option for them. We can go to the next slide. So now we're just going to go more into detail about how HPV is actually related to cervical cancer. So this diagram shows how HPV infection starts. The virus enters through tiny wounds in the cervix and attaches to the bottom layer of cells. It then copies its DNA inside those cells and spreads upwards as the cells grow. In most people, the immune system clears the infection, but if a high-risk HPV type stays for years, for example, like strain 6, it can insert its DNA into our cells and turn off the safeguards that normally keep cell growth under control. So that's when abnormal or precancerous cells can form, and over time, this can develop into cervical cancers. That's why regular screening is so important, and that's why the HPV test, again, can detect those abnormal changes earlier before they become cancer, and so you can treat them earlier rather than later and hopefully prevent cervical cancer altogether. We can go to the next slide. So not all HPV types are the same. On the left, we have low-risk types like 6 and 11, which usually cause visible warts, which can be uncomfortable but are not necessarily life-threatening. On the right, we have more high-risk HPV strains, as mentioned, 16 and 18, which don't usually cause warts. Instead, they silently change cervical cells. So over time, these changes can become precancerous and eventually develop into cervical cancer if not detected. Once again, this is why screening focuses more on those high-risk HPV strains, as majority of cervical cancers start with these sorts of strains and types in particular. can go to the next slide. So cervical cancer is one of the most preventable cancers in Canada. So nearly every case is linked to HPV, which means prevention is achievable. And so the two main strategies is first the HPV vaccine. So this is recommended for girls as well as to boys across provinces in Canada. When given before someone is exposed to the virus, the vaccine protects against the strains most likely to cause cancer. Just 1 or 2 doses for younger kids or more for those with weaker immune system can provide lasting protection. So those vaccinated at a younger age experience the greatest benefit. As you get older, the efficacy or the effectiveness of the vaccine starts to decrease. So it's best to get vaccines when you are younger. Secondly, as we mentioned a few times now, screening is really important. So it used to be the Pap test, and now the HPV test allows us to catch those abnormal changes in the cervix quite early. And so we can hopefully treat and deal with the cancer earlier on. Once again, the infographic highlights that reducing smoking as well as secondhand smoke exposure can further lower the risks as well for cervical cancer. So altogether, vaccination, screening, and having a predominantly healthy lifestyle can mean that cervical cancer is almost entirely preventable in Canada. We can go to the next slide. So I mentioned a little bit about the vaccine for HPV or for cervical cancer, and it's called the Gardasil vaccine, or otherwise known as 9-HPV vaccine because it covers the 9 strain. It's given like any other vaccine. It's usually a shot in the arm, and it allows your body to create antibodies or a defense system ready to take on HPV if you were to acquire it later on or after getting the vaccine. And so individuals, both male and females who are aged 9 through 45 are able to get the vaccine. So specifically across Canada in grade 6, both boys and girls will get the vaccine. And then if you didn't get it in grade 6, you can also get it later on in life. So in particular, we know that individuals who are between 9 to 20 will get 1 dose. Individuals who are 21 to 26, it's recommended to get 2 doses separated at least kind of 6 months apart. If you're older than 27 or 27, you're still able to get the vaccine. It would just, again, need to be 2 doses. And individuals who are 9 years of age and older, but who are also immunocompromised or living with HIV, for example, it's recommended to get 3 doses. And so we know without vaccination, it is estimated that 75% of people in Canada will have at least 1 HPV infection in their lifetime. So it's worthwhile to get the vaccine to prevent an HPV infection getting to the point where it might cause cervical cancer. In terms of adverse effects, they're quite minimal in the sense that you might have some site-specific effects. So you might get a bit of redness or swelling after the vaccine that should go down within 24 to 48 hours. Some systemic impacts, again, they're very unlikely, but some people might get a fever or headache, which usually, again, resolves within a couple of days after the vaccine. It's usually not long-lasting. You can go on to the next slide. So we mentioned, again, the people that get the vaccines include males and females 9 through 45, and then you can get it older as well. But some of the groups that we wanted to highlight that are kind of considered high risk and that should consider to get the Gardasil vaccine if they haven't already are individuals who are gay, bisexual, or individuals who have men who have sex with men, or men having sex with men, I should say. People with HIV who are immunocompromised, as mentioned, who may already have a history of angiogenital warts or other HPV-related precancers, people with a history of sexual violence, and again, individuals who may live in more rural or remote areas, and then recent immigrants or refugees, again, because they're at a higher risk for cervical cancer in general. Go on to the next slide.
Okay, now we're going to go through the stages of cervical cancer. Staging is important because we want to see how the cancer has spread, and this will help us decide on treatment. So for stage 1, this means the cancer is confined to our cervix. So within this stage, there are 2 main subgroups, stage 1A and stage 1B. 1A refers to microscopic disease, which means that the cancer can only be seen under a microscope. If the tumor is no more than 3 millimeters deep and no wider than 7 millimeters, it is called stage 1A1. If it is more than 3 millimeters, but not more than 5 millimeters deep and not wider than 7 millimeters, then it is stage 1A2. For stage 1B, on the other hand, this means the cancer is visible and larger than stage 1A2. This stage is further divided by tumor size, less than 2 centimeters, and it's 1B1, between 2 and 4 centimeters, 1B2, and 4 centimeters and greater, it'll be classified as 1B3. In stage 2, the cancer has grown beyond the cervix, but has not reached the pelvic wall or the lower third of the vagina. So for stage 2A, this involves the upper 2/3 of the vagina without spreading to the perimetrial tissues, while stage 2B means the tumor has grown into the perimetrial tissues, but still has not reached the pelvic wall. Now we'll move on to stage 3, which indicates that the disease is more advanced, but still localized. For stage 3A, the cancer is spread into the lower third of the vagina. For stage 3B, this occurs when the tumor extends to the pelvic wall or causes blockage of the ureters, which can therefore interfere with our kidney functions. And now finally at stage 4, this is the most advanced stage of cervical cancer. In stage 4A, the disease has invaded nearby organs, specifically the mucosa or the bladder or the rectum. In stage 4B, the cancer is spread to distant sites, such as the lungs, liver, bones, or distant lymph nodes. We can move to the next slide. But we have several treatment options. The choice of treatment depends on the stage and size of the cancer, as well as personal choices. For small cancers that are still confined to the cervix, surgery is often the first treatment option. In some cases, a cone biopsy can remove only the cancer while keeping the cervix intact, which allows for possibility of future pregnancies. A tracheolectomy removes the cervix and some of the surrounding tissue, but leaves the uterus still in place. There's also a hysterectomy. This would remove the cervix, uterus, and part of the vagina and nearby lymph nodes. And this procedure can cure the cancer, but it will eliminate options of pregnancy. Radiation therapy is another option. It uses high energy beams to kill cancer cells and is often combined with chemotherapy for cancers that have grown beyond the cervix. Radiation can be delivered externally, targeting the affected area from outside the body, or internally with a small radioactive device placed inside the vagina for a short period. Chemotherapy uses strong medicines to kill cancer cells and is commonly used alongside radiation for advanced cancers. It can also be given before surgery to shrink the tumors or at higher doses to help control the symptoms. In advanced cases where other treatments are no longer effective, immunotherapy can help the immune system recognize and destroy cancer cells as well. Next slide.
Do you want me to talk about this, Anaya and team? Is that okay?
Yeah.
Sure. So let me just quickly go back to here. So what we're talking about is some of the, taking a step back and talking about some other cancers. The main ones being breast cancer, colon cancer, and lung cancer. There's other cancers as well. We'll talk about them in the future. First one being breast cancer. Especially right now, we're talking about women in this webinar, particularly not just women, but that has been the focus so far. The Ontario Breast Screening Program, OBSB, is a center that follows the standards of screening, and they put guidelines out and resources. You can see that the recommendations for screening are as follows. So from 40 to 49, the recommendations are now by self-referral. You can go to Ontario Health and get a mammogram, and there's nuances about what to do afterwards. Sometimes there's MRIs. We're not going to talk about that, but the question is that the point is that it's one of those things where the earlier you catch it, the better. Hence why you no longer need a referral from your family doctor and nurse practitioner if you're in the 40 to 50 category. Beyond that, where the risk goes higher with age, 50 to 74, you have routine mammogram recommended every 2 years, covered by OHIP, self-referral as well. And then for high risk, 30 to 69 is people with genetic histories, family histories, certain genetic mutations. They're recommended to also get it, but it's a huge, an extended age range, as you can see, 30 to 70. And then for people 75, it's more of an individual decision. They can talk with a family doctor, other doctors, because of the age is a little, the risk factor is a little bit different. But the key thing is, again, you don't need a referral for this. People with a family history should especially be aware of this. And also there was some nice statistic that says if you start screening in the fifth decade of life, the 40 to 50, the difference is not dramatic than if you start from 50 to 74. You avoid a few extra unnecessary biopsies. The difference is not dramatic. So it's not a concern. If someone wants to get it, go ahead and do it. Okay. Moving on to colon cancer. Take it away, team.
Yes, so for colon cancer, there's kind of two major tests. We have the FIT test as well as the colonoscopy. So the FIT test is essentially a stool sample, and this is done roughly every 2 to 3 years if you're average risk. And the government of Ontario describes someone who is average risk as being between ages 50 to 74 and who has no parent, sibling, or children, so first degree relative, that has been diagnosed with colon cancer. When it comes to a colonoscopy, this is a scope test. So a scope is placed to look inside of your colon, and this is for individuals who are at increased risk. So this is usually people with family history of colon cancer. That includes one or more parents, siblings, or children with the disease. In terms of the frequency, it'll depend after the first kind of colonoscopy to see what the prognosis is, if it's negative versus positive, and the degree of risk that your family doctor will kind of make a judgment. We know for starters, you want to start the colonoscopy screening if you are high risk 10 years before your first degree relative got diagnosed. So for example, if your first degree relative got diagnosed at 50, you would kind of start screening at 40. And one of the points that I want to make before we go on to lung cancer screening is that with HPV, with colon cancer, with breast cancer, these tests tend to have a lot of stigma around it, surrounding them. People tend to be very uncomfortable with the fact of having to go for a colonoscopy or having to go to the doctors and get a pap test done or HPV test done, as well as mammograms are not the most comfortable thing in the world either. But hopefully we do these screenings and we talk about it to make it more part of our everyday conversation, so the stigma is removed, and that hopefully people feel more comfortable having these conversations with their physicians, and so they can get on track with making sure that these screenings are done and they're kept up to date, because at the end of the day, health does matter more than anything. So hopefully through this presentation, you have felt like the stigma has lifted a little bit, but we can move on to lung cancer. So we can go to the next slide. Lung cancer screening is not as invasive as the other ones. So usually you would get a low dose CT scan. So this is usually between 55 to 80 years old, as well as if you've smoked cigarettes every day for at least 20 years. It doesn't have to be consistently for 20 years, but if you've smoked for or in a row, I should say, doesn't have to be in a row, but in general, if you've smoked cigarettes every day for at least 20 years, you would qualify for it. And a low dose CT is usually the way that we go for lung cancer to see if there's anything abnormal with the lungs. So that's that.
Yeah, and that brings us to the end. Dr. Curnew, what are your thoughts on all this? We talked a lot about prevention, cancer prevention. You have family history of heart disease, dementia. What are your thoughts?
Well, first of all, when I started clinical practice, is that heart disease was the #1 killer. If you had heart disease, you had an 8% chance you were going to have another heart attack or stroke. But now that's changed. We have better therapies, and one of the best therapies for heart disease is being on a high dose stat and low dose ezetimibe. You can actually decrease the risk or delay the risk of heart disease by 60%. So my vaccine for heart disease is good lifestyle changes, and statin and ezetimibe. Now, when it comes to cancer, is that it's much harder. Cancer is a 40-year process for most of us. Every day, we're exposed to 5,000 different foreign substances called antigens that your immune system has to fight. And we also learned that vaccines are best in younger people. We have a good immune system. Obviously, the first 6 months, the first couple of years of life, you have a very weak immune system and you're dependent on mother's maternal transfer antibodies, and breast milk is really important in that circumstance. Um, so to prevent cancers is that the best number one preventive strategy, if you smoke, stop or reduce, keep a good body weight, eat a healthy diet, but more importantly is that the impact of vaccines. We have a preventable disease. We just learned that over 99% of cervical cancer is caused by a virus. And what I didn't realize as well is that the virus can affect other parts of the body. Um, and we need to think about uh, this is just phenomenal. Now, the downsides of vaccines are very, very small, and uh, there's always a trade-off, and the trade-off is wonderful. In my squash club where I play, unfortunately, there's a good friend of mine. His wife had cervical cancer, and basically has not been able to be playing squash or being active for about 3 years. And it's been a great stress on her family. Um, that's now preventable. So you have to decide if you want to do this or not. Um, and I'm truly amazed. Um, and when it comes to multiple vaccines, is that I didn't realize that COVID goes into atherosclerotic plaque. It lines your blood vessels. It ages your brain, ages your heart, accelerates diabetes. Influenza, you can actually decrease by getting your flu shot every year. You can decrease the chance of having a heart attack or stroke. And now the data on shingles is quite remarkable. We looked at studies when the policy of changing getting shingle shots, and that just changed dementia risk. So I think we need a lot to explore, and these other things that harm us, but we can make a bigger impact. I'd be curious to see final thoughts from anybody, from other people. Is I'm just amazed the power of modern medicine can be. Um, we go back in history or from polio, measles, are just some examples. And I know people are very much don't know who to trust, and all I can tell you is that people in healthcare have devoted their lives to try to do what's best for yourself. So listen to the experts, and you make your decisions, but be careful. Um, and there's good advice, there's bad advice, um, and I learned a lot today. Any thoughts from anyone else?
Yeah,
I was just going to
yeah,
say,
Hanai, go ahead. Yeah, go ahead.
just a tiny little tidbit.
Yeah.
While I was preparing the presentation, I came across a research paper from 1901. It was a scanned document, and
Mm.
there was this physician in Britain talking about this new cancer, and they think it has something to do with the female reproductive system. And it was almost like a bill of death that if you got it, that you wouldn't ever recover from it. And so it turned out to be cervical cancer. And it is like what Dr. Curnew mentioned, how far we've come from not being able to rectify that to now having a lot of great prevention as well as vaccines to help keep people here longer.
Yeah, what I was just going to add on is I heard a nice analogy from Peter Attia. It was about statins, but it relates to vaccines too. So somebody asked him about, hey, what's your opinion on using pharmaceuticals for any kind of prevention? And his idea was, instead of talking about, the 60% risk reduction, he talked about, imagine you had a contractor at your house and they told you, hey, look, I don't believe in hammers and this and that, the other tool, and then you'd be like, you're crazy, you wouldn't you use all the tools in your disposal? So same thing with vaccines. Yes, there's behavioral and risk factors of the environment you can control for some of these cancers, heart disease, etc., but why not use all the tools? Why not just be punitive and say, I'm going to go with lifestyle changes? It's like that Swiss cheese model for COVID and flu. use mask, use distance protection, use tests, use Paxlovid, even though it's expensive, use vaccines, use this, that, the other. So it's not one thing, it's many things. And that's why we're doing this.
One final thought is that we learned that your immune system is good when it's young. And I've seen pictures of the immune system of your immune system peaks in your teenage years. Um, and as you get older, your immune system starts to cave in. And that's why after the age of 65, your immune system is not as good. So people say to me, well, listen, I haven't had any infections all my life. Um, I don't need vaccines. Well, I train my immune system by exercise, eat healthy, keep my weight down, but I also train it with vaccines, and so those to think about. I'm going to be very provocative right now. I think I know how to prevent heart attacks. I think I know how to wipe out atherosclerosis. And you're born with an LDL cholesterol somewhere around the 1 range, and you prosper. And if you can keep your LDL cholesterol over your lifetime less than 1.5, heart disease may go away or may get rid of the vast majority of heart disease. And we're going to actually look into that a little bit more and invite people who want to how to wipe out heart disease. So we tend to start your first oil change in your car when it's brand new. When your health change, we sort of wait till we're 60s and 50s until we're older. We need to think about earlier intervention. And also, boy, a good doctor makes a good diagnosis. A better doctor prevents disease, and vaccines are part of that repertoire. Other things too, as well. One story is pneumococcal pneumonia. I'm not sure if people remember when we grew up or when I grew up as a young individual, I had my tonsils taken out. People had ear tubes put in place, and that was caused by a bacteria called pneumococcal pneumonia that lies in your nose. You now get vaccinated for this, and you actually prevent need for tonsil operation, need for tubes in your ears. And also, little baby Johnny won't transmit the bacteria to grandpa, and grandpa won't die from pneumonia. So there are other, excuse me, about vaccines. It protects you, but it can help protect other people as well, depending on the illness there. So lots of good things to say about this. Yes, there are risks to vaccines. Nothing comes free, but the risk is really very small and well tested. So vaccines go through extensive testing, and we're always looking to do better. And I'm really excited about how this has changed. When I started off my career, I was working in a coronary care unit. I loved to see people in the emergency room that were sick and got a lot of thrill about treating people's heart attacks, congestive heart failure, and other medical problems. Now that's failed prevention. I don't want to do that anymore. I want to prevent you from going to be in the hospital. And vaccines are part of that repertoire. Thoughts from anybody else? If not, I
That
want
was
to
well
thank you.
said. That was well said.
This has been a wonderful presentation. You can see that number 5 is chronic respiratory diseases. And so, one way of decreasing that is not smoke and good preventive strategies and vaccines. And now we can make an impact on cancer. Not all cancers are infectious in origin, and most cancers are a combination of the environment, we're discovering the different infections out there as well. And what a story. What a story. Thank you so much. And I wish everybody a great night, and we'll see you next time. Good night, everybody.